So the next speaker, Dr. SHIVKUMAR, will be talking on prevention and early identification of posterior capsule rupture. Dr. SHIVKUMAR heads the cataract department at Aravind Eye Hospital, Tirunelveli. We have some chairs in the front if some of you would like to.
Delegates, and thank you, madam, and the organizers for this opportunity to talk about prevention and early recognition of PCR. We know that the standard of care in cataract surgery is the placement of intraocular lens in the bag, but capsular complications prevent the placement of the IOL in the bag. Rupture is the most common capsular complication that we face as cataract surgeons. It is imperative that an early recognition happens and we minimize the damage like shown in the previous talk, which gives better outcomes. So how do we recognize a PCR? It starts with subtle signs like the pupillary snap sign described by Ronaldo. The twitch of the pupil happens during hydrodissection. The rotation may be difficult, especially if a freely rotating nucleus stops rotating. Things that the pupillary is there. You are unable to hold a piece for chopping. If there is a nuclear piece which is tilting, there's an altered plane, or there's a flutter. So let's look at some of the videos. You can see that this is the first shot. It was working. No, it's not. It's working.
So I think as the
while this is sorry.
Yeah, go ahead.
While this is coming on in the vitrectomy, points which we need to remember is think of where the irrigation goes. So if you keep irrigating into the PCR area, then it will become hydrated and more vitreous will keep coming. And the second thing is the level of irrigation. So try to keep it over the iris, not directly aimed at the iris margin. Then it will again irritate the iris and the pupil will start coming down. And if you don't see the periphery and the pupil is already down, please start using iris hooks or dilating devices so that you can see the extent of the PCR and you can assess how much of capsule is left.
So you can see here that there's a chop which happened in the periphery, and now look at this. The tip is not getting occluded. It's not impaling into the nucleus, and you can see a little bit of a tilt of this side of the nucleus which happened now. And you can see that the chop isn't happening at all because probably vitreous has got into the tip. And then when he removes the tip from there, you can see the flutter, and this looks quite ominous. Coming to the second one, you can see that the surgeon, again, yeah, I'll play the videos. So you can see here that the rotation doesn't happen, and when he's trying to just pick up one, there's a slight flutter, and he collapses a bit out thinking that there's danger, and you see that the other one actually slips down. Then the second one, the third one, you can see that there are two ring nuclei almost of equal size, but when he's rotating, see that this starts hiding under the iris. It goes under a smaller portion of the iris. And now you see the large portion does come out, and you know that all this was hiding underneath that, and once things cleared up, you can see that this area corresponds to the area of the PCR. So going back to the presentation again. So in recognition, we also need to see about loss of nuclear piece followability, inability to aspirate the cortex or the epinucleus, inability to aspirate the cortex of the epinucleus, or a sudden deepening of the anterior chamber, distortion, peaking of the pupil, and lines on the PC. So here again, you see the epinucleus came fast, but the rest of it isn't coming, and that means that there's some problem, and you can see that there's a corresponding PCR in that area. Then there may be punched out holes that you may see, and this is due to the instruments, maybe the phaco tip or the IA tip or even this cannula that causes this small demarcated PCR. And look at this carefully. This is a PPC where all cortex is being aspirated slowly. But now watch here, you can see a line. This is suggestive of a PC dehiscence that's happened. You can see the double track line now, and you know for well that there is a PCR underneath. Also, after implanting the IOL, if there's a constant decentration or a tilting of the IOL, or after everything is over, if there's an inability to form the anterior chamber in spite of a good wound, then please suspect a PCR. So how do we go about preventing a PCR? We have to remember that there are two mechanisms which cause a PCR. One is an incomplete CCC or a tear in the CCC which extends to the periphery through the zonules into the posterior capsule, known as the wraparound. And the other is a direct trauma to the posterior capsule with any instrument like the phaco tip, the irrigation aspiration tip, or the chopper. But remember, even a bolus of BSS is an instrument. The first thing is to know thy patient, that is to do a good preoperative assessment and see whether the patient has got any systemic disease. What is the anxiety level of the patient, whether he can be taken under topical or needs a block or even maybe a sedation, whether there are orthopedic problems which would preclude his lying down for the duration of the surgery, and if the patient is on any medications like the recently one like tamsulosin, which makes surgery difficult. And more important is to have an idea of the entire eye, especially those who are prone to PCRs, looking at the grade and density and type of cataracts, the existing comorbidities like non-dilating rigid pupils, PXF, shallow AC, primary angle closure, glaucoma, and in the biometry, to pay attention to the AC depth and axial length, which are important for knowing whether this can go for a PCR or not. The other thing is to know about the machine, whether the machine is capable of having the appropriate parameters to match the nuclear grade, whether it is safe enough to maintain the anterior chamber throughout the surgery with different flow rates and vacuum, what are its limitations, and also a little bit of diagnostics and troubleshooting, like not able to get the vacuum because of an occlusion of the phaco tip, or being very aware about the bottle height as well as the amount of BSS in the bottle. Know our own limitations like case selection, which should be done properly, not beyond our capacity, appropriate adjuvants used at the right time like the viscoelastic Cyrus hooks, capsule hooks, and go by our strengths, do what we can do best. And also look at the instrument availability like microforceps, micro scissors, which will be required, like especially in cases like intumescent cataracts. Now coming to stepwise prevention, the capsular exit should be adequate and complete. And if it is a runaway, then go for the Brand-Little maneuver and do a risk assessment at the end of it and see whether you can continue with the phaco. And if it's an SICS, see that you maintain the chamber and take due care in the extended axis. Now, one small tip is that you look at the angle between the fold and the flap, and it should be at right angles when you're proceeding with your rexis. So you can see that this right angle is there, but when it starts to move out, it means it's time to refill the chamber. So this is likely to run out if you continue, and therefore fill the anterior chamber. See this at right angles, and this is how it should be. Coming to the other step, which is very important, is the hydro procedures. The hydro procedure should be gentle, and it should be customized. That's for you, your habit, going with the same area, with the same amount of fluid being injected, the caliber of the cannula and the syringe being the same, with the same force. It's more of a proprioceptive learning, and with the same number of injections. And then if you want to repeat it, my advice would be to repeat it after debulking the lens with the phaco. So this is my approach. I just go to the 4 o'clock position, debulk again, and then inject, hydrodelineate, press again, go to the other end, and then slightly re-inject a little bit more. Only 3 injections. Here again you can see a repeat of it in another case. Fluid under the nucleus, a little bit of hydrodelineation, and then a little bit of injection on the other side, and then it's done. Then, during the phacoemulsification, we should employ the proper technique. We should take care of the phaco settings to prevent surge, whatever is necessary, like changing from the fixed to the linear settings, to decrease the flow rate if necessary, and to introduce viscoelastics just before the last piece. Awareness about the second instrument is also very important. It should be in the proper position and plane, because the chopper can hit the CCC and tear it. The sleeve position to maintain the anterior chamber, do not come out of the wound, otherwise the AC could collapse, and you should have a sufficient inflow and the bottle shouldn't get over. So let us look at the trenching. One should always remember that it's from a convex to a flat surface to a concave surface, and if the direction is not changed accordingly, you could have a very deep trench at the periphery and even a touch with the probe and have a PCR there. This is about the second instrument. Be especially careful, especially in smaller rexes. You can see that the chopper needs to be constantly inside the rexes and constantly in the plane of the nucleus, not in the plane of the CCC when you are going. Try not to go too peripheral when you are dividing, especially in a small CCC. Now the nucleus has always to be impaled and grasped at the center where it is the hardest and not in the periphery. See that when you take on the softer portion in, it goes in so fast, and if the setting is not right, you could have a PCR. And also, never try to hold a nucleus in the periphery. Finally, the tip position should always be the safe area of phaco, which is right at the center, far away from the cornea, far away from the PC, and far away from the margins of the pupil. But if a piece does come under close to the wound, don't slip your probe back to catch it. Use your second instrument to bring it back into the flow and then emulsify it. Then PCR needs to be prevented also with the proper cortex and irrigation and aspiration. Have a look at the settings, the position of the sleeve so that it does not slip out of the wound, especially during subincisional cortex. The position of the aspiration port, it should never turn towards the posterior capsule. And finally, the IOL placement. The injector mechanism chosen, if possible, could be the screwing type rather than the push, because sometimes it could be tight. Check the injector mechanism before loading the IOL, and the IOL should be loaded properly so that it does not shoot out and cause injury to the piece. Finally, we come to the human element, the most important, I would say. To avoid mental stress, dissociate from personal problems, no comparisons with other surgeons or yourself, and meditate if you need to remove the clutter. No ego, be ready to step back in the best interest of the patient, because he has a life to live after your cataract surgery. Cataract surgery is a learning, not an experimentation. And with every complication, introspect, analyze, and prevent. Thank you.
Very useful. Very useful tips from Dr. SHIVKUMAR on how to recognize and prevent a posterior capsule rupture. But I think the important thing is, when you do suspect a rent, when things are not going well, it's always better to err on the side of actually confirming it. Sometimes we think things are not going well, like you may see the nucleus equator on one side when it should not, when you have the whole nucleus intact and the nucleus equator is seen in the pupillary area, it means there is either a rent or a dialysis. In that case, it's better to stop, reassess, and then proceed. Because if something is not right, you better take care of it earlier, because early identification can help in managing things in a much better fashion.